Well, thank you, Gail, and thank you, Susan, for another welcome to a beautiful place here in the city of Nashville. Wonderful place to have a sort of public event. I used to think of it like as the market square in Nashville, although it's covered over so that we can meet even when it's too hot or too cold outside. Larry Churchill is the Ann Geddes Stahlman Chair of Medical Ethics at Vanderbilt's Department of Medicine, and he's co-director of our Center for Biomedical Ethics and Society. He's also got secondary appointments in the Divinity School and in my philosophy department. He was educated at Rhodes College, where he majored in philosophy, and at Duke, from which he received a PhD in religion and culture. Larry entered the field of medical ethics and humanities in about 1973-74 as a member of the first class of fellows of the Institute for Human Values in Medicine. Prior to coming here to Vanderbilt in, I think, was it 2002? Yeah. Larry Churchill was professor and chair at the Department of Social Medicine at the University of North Carolina at Chapel Hill, and he was cited there for excellence in his teaching of medical students. Professor Churchill has published, as you might expect, widely in many areas of medical ethics, including research with human subjects, end-of-life decision-making, social justice questions, and the ethics of US health policy. He's written a number of important books, none of which we have on our display. I think the reason is people have taken them out, you know. Especially on healthcare and public policy, including rationing healthcare in America, self-interest and universal healthcare, which was selected a Choice Magazine Outstanding Academic Book for 2005, and ethical dimensions of health policy with Oxford University Press in 2002. His work in ethics and health policy, was the basis for his election to the Institute of Medicine in the National Academy of Sciences in '91. His current projects, it's hard to just list everything this guy does, include research on the interplay between religious and genetic understandings of human nature and personal choice, and a study, I think this is terribly important, of what makes a healing relationship in medicine. Larry is an expert in medical ethics, an area which deals with some of the most pressing personal issues of our time. Indeed, not just our time, perennial questions which escape none of us, such as how we deal with the end of life. He's made major contributions to a book called Parting, a handbook for spiritual care near the end of life, which in 2005 won a Best of the Best award from University Presses. But when we consider just how inefficient our American healthcare system is in delivering healthcare to all Americans, even as our technology ranks with the best in the world, I think it's his interest in public healthcare policy that's the most important. And I speak here as someone who, grew up in both the Canadian and then the British healthcare system. And so I've seen sort of different models at work. And the most important healthcare program in our country, Medicare, lurches from crisis to crisis. And medical bills, as I understand it, are the commonest cause of bankruptcy in this country. Why can't we seem to get it right? Well, I'm delighted to welcome Larry Churchill here today, where he's going to be talking about Medicare, the phony crisis, and the real crisis. Larry.
Thanks very much. Thanks, David, for inviting me to this. I'm going to ask if there's a way that we could dim the lights some, because I think you'll, yeah. Wonderful. I know that's a risky business right after lunch, but I'm a little worried that some of the print on the slides is going to be a little too distant for some of you in the very back, but let's just see how it goes. I'm going to be talking through most of this. I want to talk for about 20 to 25 minutes max, because what is fun for me in relation to this is the kind of questions and responses you have to some of the ideas I'm putting forward. I know what I'm going to say, and it's kind of boring to me just to hear myself say it, but your response is where I learn. So hopefully most of the time we'll go in that direction. I want to ask two questions to put on the back of your minds at the very front of my talk, and they are these: are we all in this together? And secondly, what does society owe elders? I think both of these are fundamentally important questions in terms of decisions we'll be making over the next decade about the future of Medicare. A very brief history of some of the things that have been accomplished by Medicare that we may not think about. One is, and perhaps most important, a reduction in the poverty level of the elderly, which was 35% of the elderly lived in poverty in 1960. That's down to 9% now as of 2005. We also had a forced desegregation of all hospitals 1 year after the passage of Medicare. Medicare is the largest funding source for graduate medical education, so every resident and intern that you see in hospitals has salary support from Medicare. It has subsidized rural hospitals that could not have survived in the current competitive environment. And think about this, it has created the field of geriatric medicine by providing a funding source for specialists who care for the elderly, and the impact on the economic prospects of the working class and their children has been profound. More about this later. Everybody agrees that there is an impending and sort of recurring Medicare crisis. It's easy to see from one point of view why this is true. By 2030, the portion of the population over 65 will be roughly 20%. That's up from something like 12% in the turn of the century. This means that the Medicare enrollment will practically double during this time, and that this is going to be a much greater problem than the problem we tend to discuss, which has to do with Social Security, since the Medicare growth rates far surpass those of Social Security. In fact, the growth of medical cost is 2 to 3 times the Consumer Price Index. So other goods and services, medical care costs usually 2 or 3 times more each year than the other goods and services in the basket. And of course, we added the new prescription drug benefit, which will add $1.2 trillion in expenses over the next decade. These are the government's own estimates of the cost. But here's one of my basic points. Demographics notwithstanding, the seeds of this and similar Medicare crises were present at the very creation of Medicare. So I want to give you what I'm calling here a very short history of the beginning. As you remember, this was enacted in 1965 following the landslide victory of LBJ, and in which the Democrats controlled Congress by a very wide margin. This was part of the Great Society programs, including issues such as civil rights, education, poverty, housing, and so on. And it followed a policy design of the advisors from the Truman administration, principally Wilbur Cohen and I.S. Falk, and based Medicare on the financing framework of Social Security. So Medicare was understood as social insurance. That is, a social rather than an individual contract, so that the contributions and premiums that people paid, the contributions when they're working and the premiums later after they're retired, bared some relation to the benefits. So the program is understood largely as an entitlement, not as a welfare program. And this is to be contrasted to the public assistance programs in medicine and healthcare that we have, TennCare in Tennessee, Medicaid programs all over the United States, in which there is no individual contribution by the recipients of the services, and the benefits are paid from general revenues and therefore seen as a kind of charity. So the differentiation between Medicare and other kinds of programs is very important for understanding what it is now, how we understand it, and its potential future. Having Medicare understood as a social insurance program and using this model eliminates a lot of political problems, the problems we always have contributing to the poor in terms of whether or not they are sufficiently deserving for our care, a part of the political rhetoric in this country as long as I can remember. And it provides a kind of very strong social mandate. The benefits are seen as rights, similar to Social Security. The program is seen as public property, not as just another government program. Following the Social Security model means that for Part A, as you know, the hospitalization insurance is funded through payroll taxes of current workers and employers and put in a trust fund. Think about the 2000 presidential election in which Al Gore kept talking about protecting the lockbox in which our Social Security and Medicare funds are stored. Part B, the supplemental medical insurance which pays physician bills, is funded by beneficiary premiums and also through general revenues. But as you remember, at the creation of Medicare, although we followed this collective strategy for gathering the funds to pay for the benefits which would follow, we used a free market and competitive sort of mechanism for the distribution of funds in terms of paying for hospitals and physicians. So I want to say that despite the very broad consensus there was in 1965, the potential for polarization over Medicare is evident from the very beginning in the tension of a social insurance collectively understood program combined with a private market provision for the distribution of those services. And this tension shows up again in the 2003 legislation which provided a drug benefit. Okay, I'll come back to some of these themes in a few minutes, but right now I want to provide what I'm calling a very short history of the Medicare crises. A crisis by my count has occurred 3 times within the past several decades, each time when the period to financial insolvency was 7 years or less. And periodic crises are virtually assured given the Medicare funding structure. This is borrowed from a really ingenious book by one of my former colleagues, John Oberlander. The first crisis was in the early 70s when we thought that the problem was overutilization of services, fraud, and abuse. The solution was thought to be professional self-regulation, and the policy strategy was professional standard review organizations. In the early 80s, it was thought to be retrospective reimbursement, paying people the full bill for whatever was submitted from hospitals and physicians. So we went to a system of prospective payment in terms of hospitals, diagnosis-related groups where you put a sum of money out for a diagnosis and say to a hospital, do the best you can in terms of using these funds to manage this person's illness. And in the mid-90s, the crisis was thought to be the fee-for-service system for compensating physicians under Medicare. And so we went to a very competitive managed care model in which we began to offer for the first time a private HMO choice for Medicare called Medicare Plus Choice. And that got replicated again, of course, in the 2003 legislation in Medicare Advantage. So, one of the important points I'm trying to make is that there is a phony crisis and there's a real crisis. The phony crisis is this, that a periodic crisis is absolutely assured because of the financing model that we are using for Medicare, which uses payroll taxes and a trust fund to measure solvency. If we were financing Medicare in some other way, we would not have a crisis. Think about it this way. We do not have periodic recurring bankruptcy crises in our defense program, or in foreign aid, or in our education programs. Maybe we should, but we don't. because we are financing those programs in a different way. We do not have some sort of correlation between a contribution made by workers and a trust fund and a lockbox that's supposed to be adequate to cover future needs. So phony in the sense that it's a function of a financing mechanism which was designed into Medicare in the original legislation because we decided we would follow the Social Security model. The real crisis, of course, that we also talk about is that the health needs of the elderly are far greater than they are for younger groups of people, and because we have expanded the benefits of Medicare programs periodically. Also, we have the burden, as I talked about earlier, of growing numbers of elderly in relation to workers. So fewer workers contributing funds for a larger number, an ever-increasing number of retired people. Also because of healthcare inflation that, as I mentioned earlier, healthcare costs 2 or 3 times more than other goods and services in our society. And because of public ignorance. This is the last quotation here, the last item. "Keep government out of my Medicare" is a phrase that one hears, actually. This is a direct quote, I think, from a woman in Florida who was worried that her benefits were going to be cut and the government was going to intervene in some way, without, presumably, the assumption that this is a government program through and through. In fact, by all measures, the best loved healthcare program in the country. We got to this point in terms of confusion about distinguishing a kind of financial mechanism crisis from the real crisis, and of a certain kind of framing of the issues out of what happened in the late 1980s. This is what I'm calling the political and social fallout from the collapse of catastrophic coverage. This was a part of the legislation that passed in the 1980s when we began to realize that Medicare didn't cover nearly enough. Congress passed catastrophic insurance, which would remove some of the limitations on what Medicare would pay when people would spend long periods of time in the hospital and incur costs from very serious invasive procedures. It wasn't understood when the legislation was passed. It wasn't understood sufficiently that, in fact, the recipients, the retired, would in fact be paying some of the cost of this in terms of an increased premium. So there was a tremendous educational problem. There was a tremendous mobilization by the AARP and by other groups who were saying this is categorically unfair. You have never asked the elderly to bear this kind of cost for increasing coverage before, and we want this repealed. And in fact, the pressure was so profound that it was repealed in 1989. What happened in this debate is that it set the stage, along with the Republican victories of 1994, for polarization of our understanding of Medicare crises along ideological lines. And that continues into the present. It continues to show up, for example, in the 2003 legislation which provided the drug benefit, because the more equally profound change in that legislation was that there will be a very marked uptick in the pro-competition philosophy with regard to how Medicare is understood. Rhetoric about an ownership society and about risk sharing so that individuals were themselves taking a larger degree of risk in terms of paying for the benefits and in the curtailment of benefits was really a part of the rhetoric of the 2003 legislation. One of the things we got were, of course, standalone private drug plans. We also got an updating of the Medicare Plus Choice, which went through in 1995. Now it was called Medicare Advantage, which gave the organizational running of Medicare programs to private insurers. We thought so strongly about this, I'm talking collectively now about the people in power, that we thought we would in fact subsidize the private entries into Medicare. And so it cost for Medicare Advantage 11% more than it does for standard Medicare. Now, this is a very strange notion of competition in my view, but this is a true fact. We're paying an extra additional 11% for all the mechanisms that assure the privatization of Medicare for the people who want to choose that. It raises then these very fundamental questions. Are we all in this together? Do we understand Medicare as a kind of social responsibility? I'm quoting here from Robert Ball, who was the administrative director of Social Security for a very long time. Will we understand that the payment out of payroll taxes, the sense of entitlement and ownership of the program collectively is the thing we want to affirm as its most important asset? Or do we want to shift to a notion of individual responsibility, a sort of marketized pro-competition model in which we will allow people to assume much more risk and make many, many more choices? Now, whether people can actually make meaningful choices from all those options is another good question. And that would be something to think about for later on, perhaps. But the idea that we would have a system in which much of the risk and much of the responsibility is going to be shifted to the recipients of the program is an individual responsibility model to which we are moving. So we'll start thinking soon, I think, about vouchers, about supports for private insurance, which we have already done. And we will then, I think about this system far more like a public assistance program rather than a social insurance program. The framers of Medicare very clearly in 1965 followed mostly a social responsibility model, but the reforms, especially the most recent reforms, tilt substantially toward an individual responsibility model. Now, in the midst of all this is for me this very interesting question about what does society owe elders? Are elders getting too much of the pie? Do we need to start thinking about them just a little bit more as sort of greedy in relation to the rest of us in society? Do we need to think about the intergenerational conflicts in terms of what we're doing for the elderly versus what we're doing for other age groups and especially children? Is the Medicare benefit too generous now? There's going to be increasing pressure to talk about this because we are on a collision course with the cost. Well, here's one way of answering the question, is Medicare too generous? Well, Medicare covers less than half of the health care cost of seniors. I think this is not well recognized among people who are not seniors. But many of you, I can tell, likely are very aware of this. And more than 70% of Medicare beneficiaries make less than $25,000 a year. So while we have lifted perhaps a very large number of people out of poverty in relation to the passage of Medicare, we haven't lifted them very far out of poverty, which is a statistic which is not thought about often enough, I think. Does Medicare create intergenerational unfairness? Well, advocates for children sometimes talk as if that were true, and on a previous slide I was trying to indicate this. There are, and this was before actually the Drug Benefit Act was passed, there were 11 federal dollars spent on the elderly for every dollar spent on children. That's probably 14 or 15 by now in relation to the drug benefit. But I think Medicare derives a very large portion of its rationale from the burdens it actually removes from younger generations. I'm assuming here that working adults will not simply abandon their parents, but would be in some sense responsible for the health care of the elderly. I should talk about my own case very briefly here. My father, who's actually today in the intensive care unit, is 90 years old. He has 3 artificial joints. He's had prostate cancer, he has congestive heart failure, he has, in addition to that, had 4 broken limbs. He leads what is, in his view and in my view, a very good quality of life existence. He has all kinds of views about the current political campaign, which he shares with me on a twice-week basis. His medical care over the last decade would be, in my estimate, between $750,000 and $800,000. So one of the questions I ask myself is, what would have happened to him, had Medicare not been there? This is certainly not a price that I could have afforded. I suspect he would be dead. So this is one of the ways in which this question comes home to me. I think it comes home to everybody in a slightly different way, but maybe not too dissimilar from my own situation. But this whole question about the intergenerational easing of burdens, it seems to me, is again one of these facets of Medicare which is not discussed often enough. Now, I want to present here two ways of thinking about issues in healthcare in general, but Medicare in particular. On the left, what I'm calling synchronic thinking, that is slice of life thinking at an instance in time, where you say, here's a group of elderly, here a group of children, what should we be doing for each? That's a way of looking at the question which seems to me extraordinarily short-sighted. But it's a way that we are prone to think and act because we are, as Americans, temporarily, time-wise, quite myopic. We've been described by our European brethren as reactors and deniers. Seems to me pretty accurate in many instances. But if we had a diachronic or across-time perspective, we might be asking about the needs and interests of a total population of people as they go through the life process. So we might be asking, what should we be doing for people when they are children, when they are young adults, when they are middle-aged, and when they were elderly, with the idea that with good luck, all of us will pass through those stages. And so we all have something at stake at what happens at each of those stages in terms of the medical care that's given. Some people say, well, why don't we just increase the Medicare payroll tax? And this is just a quick review of what the taxes looked like. In 1966, the rate was 0.35% to a maximum of $6,600. Of course, that kept getting adjusted, but note that while we changed the amount of income which was subject to the tax, we actually have not changed the tax rate in 22 years. And in fact, it's been off the table during most of that time. Some people have suggested that there is a political limit on Medicare payroll taxes. It's like all taxes. It's the third rail of politics. Touch it and you die. But interestingly, people who are skillful at polls have noticed that there is a profound difference between asking people, how would you like to pay an increased tax for your Medicare, and asking a slightly different question. How would you like to make an additional contribution to your Medicare? Interestingly, these same pollsters said that there is more support for Medicare and for increases in the payroll tax among the public than with the Congress. And the Congress seems to be more enamored of generational equity framework, this kind of competition between generations, than are the rest of us. I don't know what this says. I'll let you decide for yourself. So I'm going to end now with two possible scenarios for Medicare. This is scenario number one. The intergenerational conflict framework prevails. We begin to think of ourselves only as people at a point in time in terms of what we need. Individual choice and responsibility are seen as the dominant motif, so that risk sharing, transferring a part of the risk to the population getting the benefits, prevails, and the ownership society mentality prevails. It's what I own in particular that matters, not what we might collectively do. Vouchers for market-oriented Medicare plans with the value of the vouchers based on payroll contributions is unfortunately, in my view, a conceivable scenario. So we'll look at how much you put in and figure out how much your voucher should be worth. This is a part of sharing the risk. Medicare converted to a defined contribution plan, which is what has happened, of course, to most of our retirement plans. It's a question of how much you put in and how well you're able to do in the stock market, not a defined benefit plan, right? A defined contribution plan. And the government will become the funder of private plans and get completely out of the management of the programs, right? The no new tax mentality prevails. Very modest or no increases in the payroll taxes between now and 2020, which is my target year for this scenario. Rigorous caps on general revenue contributions, right? Because this is where we would make up the difference, but no, we can't do that. And the overall value of the Medicare coverage will be diminished, considerably diminished, and that will create, if you're a pro-market person, a very robust market for expanded Medigap insurance. Okay, that's scenario one. Here's scenario two. The reemergence of social insurance as a model for thinking about what we're trying to do with Medicare, going back to the original design, and the efforts to privatize, curtailed, or eliminated. An increase in the payroll tax rate incrementally from 1.45% to, let's say, 1.6% next year, 1.75% by 2012, 1.9% by 2015, and so on. So an incremental rise. I've done all the calculations about what this would cost. Let's just take the 1.75% rate, for example. The average family in the state of Tennessee would pay an additional $11.74 a month for their Medicare benefit. So one of the questions you'd have to ask yourself is, if this could be phrased in the right way, is this politically feasible or not? We would also need increased regulation over the introduction of new drugs and technologies. Extremely important. In any event, this almost certainly has to happen. And I say rigorous negotiation with Big Pharma over drug prices. As you know, it is now written into law that the government cannot negotiate its drug prices with Big Pharma. An extraordinary thing, if you think about it. And general revenue support for Part A and B. In other words, getting out from under a kind of contribution trust fund mentality. That doesn't mean you do away with contributions and the sense of ownership because people have made contributions, but you stop going into crisis because somehow, as they're required to do annually in Congress, they do some calculations and see that it isn't working. The fact that it is supposed to work would become a general kind of commitment that the government makes, as opposed to a calculation based on some kind of looking at the contribution and the imaginary lockbox. So I'm back to my original questions, and I'm almost done. Are we all in this together? And what does society owe its elders? And these are the people with whom I've had the long and sometimes controversial conversations about this. A group of practitioners, health economists, political scientists, theologians, and others. So I thank you for your attention, and I'll put this back up because this is where I want to focus. Thank you.
Okay, well, you know the drill. I'm going to ask Larry a couple of questions, and then we're going to open the questioning to the floor. I think the first question, just to sort of get us into thinking about these questions, especially about the difference between, if you like, the social insurance model and the private market model. When I think about this question, I don't think about the elderly, although I can see the importance of doing that. I think about children. And the reason I think about children is that I think if you have a private market model, I don't see how the needs of children get addressed in any kind of guaranteed way. I mean, children, it's not as if they've had the chance to build up their own, you know, insurance or equity or some sort of savings for a rainy day. I mean, children seem to me like, in any society, the innocent, the ones who need protecting. So I don't understand how you could ever get away from some sort of social insurance model when it comes to thinking about the other end of the spectrum, the kids who's, you know, who may have, you know, indigent, alcoholic, hopeless parents. I mean, surely we have, as a, you know, are we all in this together? I mean, it strikes me, surely there is an overriding social responsibility to look after the medical needs of children. I mean, so how, I know this is not the focus of your talk, but doesn't it also get, there's another way to the heart of the question?
Yeah, the short answer is yes. I mean, if you think about if you think about children, one of the things you have to think is this is the one of the greatest underserved segments of the population in the country, and then you have to worry about the irony of having a guaranteed program for the elderly, but no guaranteed program for children. And I'm very sympathetic to people who advocate for health care for children. There, you know, as you know, 8.5 roughly million children in the country without health care, and the statistics are really sobering because these children get much less, about half, of the health services of insured children. So if you were looking at you know, a great pocket of unmet need and a great pocket of vulnerability in terms of the characterizations, characteristics of people, you would have to say this is extraordinarily important. So, right, you have to ask, I think, the same kind of question with regard to children. But it becomes more striking because there's a sense in which, for children, it's impossible for them to be a part of the ownership society.
Okay, well, so the second question I have is, if you look at thinking about the two different sort of scenarios that you described for 2020, my sense was, I don't know if this was just me picking up, being extra sensitive, that you were perhaps leaning towards the second one. And I suppose I'm interested to know whether you think there is some reason to expect that we will move in this second direction, and if so, I mean, is this because there are social forces or there are ideological changes? I mean, do you have a sense of what the atmosphere is, such that we might see us going more towards this first model or more towards this second model? I mean, is this first model actually viable? Is it something that would meet the needs that you're describing?
Well, I think it depends on what you think the needs are and what you think it's more important to do. Is it important to have a healthcare system that reflects fundamentally a market modeling for how money flows and how the benefits are distributed, or is it more important to meet the health needs of the population in some kind of equitable way? I think we have to remember that markets are not designed to be equitable. Markets are designed to create winners and losers. And markets function very well if you're willing to let the losers live with the consequences. We're not willing to do that in medical care. We always pick up the losers off the street and take them into the emergency room. But so far we haven't been willing to design a system which would create equity on the front end in terms of not having to use the emergency rooms for primary care for the 47 million uninsured. So I think this scenario one is a possibility to which we have been moving over the last decade, in my view. And that's evident in ways that aren't frequently talked about in terms of the Medicare legislation of 2003. But it's there. And you know, it all depends on what you want the healthcare system to do. Do you want it to reflect the glories of market competition. You're right to think that I'm extremely cynical about the possibility for market forces, except in some very limited way, being productive for distributing health services in some kind of equitable way. So I'm hoping for a turnaround, you know, to get to solution number 2, in which there's a kind of collective responsibility for the provision of health services for the elderly, but also for everyone else. Because I consider it one of the basic or fundamental goods in a civilized world. I'm all for competition, but you have to have some kind of level playing field to start out with, and the sick can't compete. The sick, if they cannot get assistance, really are frequently systematically denied from all the other goods and services which our society offers, all the opportunities. And those opportunities don't stop at 65, as many of you know.
Okay. Obama wins the election. He's now president. He calls you, Larry, and he says, listen, I've heard about you. I need your help.
Yeah, that's trouble already.
What are the top 3 things I should be doing with healthcare? And you got a minute.
Okay, the top 3 things. The first thing that Obama has to be convinced about, and he hasn't been crystal clear, as I want him to be about this so far, although I think his heart is in the right place on this question, and that is everybody has to be included. There has to be an inclusive system. One of the reasons is that you can't control the cost without an inclusive system. I mean, if we would only learn from the Europeans and Canadians and the Japanese, the only way countries ever figure out how to control cost actually is by stopping the cost shifting and by including everybody in the system and regulating it in such a way that it works actually toward providing services. So there's a little, there's a tremendous ideological gap between our notion about how you control cost and including everyone in the system. And you're going to read lots of things which will say something like, first we've got to control costs, then when costs come down we can bring everyone into it, which is just baloney. Actually, these go together.
Okay,
so cover children, that's incredibly important to do. I would say you have to really rethink some of the marketing emphases that have invaded Medicare over the past decade.
Okay, this is wonderful. Now, we're going to ask you for, as Larry said right at the beginning, he wants to hear back from you what your thoughts are. So we're going to spend the next few minutes just collecting some questions together, which he's going to write down, and then at the end he's going to address all of these concerns. So, questions from the floor.
I have a whole lot of thoughts as you speak, and being silver-haired and probably approaching my senior years, not too many years down the road, some things that I see happening in the world, the obesity rate in America scares me because a lot of our seniors that are here today, I look around and I think there are people who are trim young people, and when I look at the world at large right now, they probably look a lot different, the world does in America than a lot of our senior citizens looked when they were younger. That scares me. The illegal immigrant population, children who are born here, the anchor babies, if you will, who are going to be going through our system at a rapidly increasing rate. The explosion of boomers, people like me and all my friends who are a big, kind of the boa constrictor swallowed the elephant that are all going to be aging out at about the same time. Coupled with the time that you have DNA testing going on, how's that going to factor into insurance underwriting? Plus, we have people at Vanderbilt and doing all sorts of medical research that are coming up with ways to prolong life. When we're 80 and 90, there are going to be probably so many medical procedures and practices that are not even there today. How is that all going to factor into what I hope will be there to take care of me when I age?
Thank you. Do we need any more questions? Yes, there's a lady down here. Or do we have a gentleman over here then? A lady.
wonder what your thoughts are on what I've heard. And I think the United States spends something over $1 trillion a year on medical services, and that half of that is spent in the last year of our people's lives. How do other countries deal with that, and do you see some way of dealing perhaps more rationally with that?
Thank you. The lady here.
I wanted to ask about risk sharing. I'm kind of puzzled about that because it would seem to me that the elderly are ill-equipped to assume more risk. And so who is it that shares the risk, and how in a market-based system?
Thank you. Yes, gentleman there.
I promise I've been paying attention, but something has eluded me here because I want to know what the third question about Medicare is.
Yeah, they never taught me how to count at Duke.
Yes, gentleman in the back there. Up here.
Do you believe the adoption of a national health program where people of all ages are enrolled would mediate the problem of taxes and financing Medicare?
Okay, thank you. And the gentleman here.
David, I hope we have another hour or hour and a half for the questions to be answered that have already been asked. But you know, when you say, are we all in this together? Certainly we are. Secondly, what does society owe the elders? I'd like to think that society owes us something that can be afforded by our government. The question that I have in addition to this is the cost of medicines these days. The fact that so many medicines are being manufactured overseas, shipped in here, and we have problems with some of those. Some of the medicines that are being manufactured in the United States are being shipped overseas, offshore, so to speak, and are sold at much less cost levels than what people are paying for here. I think it's a horrendous problem.
Thank you. The lady at the front here. And gentleman right at the back.
Yeah, obesity was mentioned, but I think that there's a health behavior crisis in our country, and all we hear about is the health care crisis. And today on the news, I think 100 students at San Diego State were arrested because of drugs, selling drugs. So it's what we eat, it's our lack of exercise, our lack of letting children run free and play and create their own world. And I just think there's a lot of issues that are not ever being discussed in the public arena.
I think it's going to have to be our last question from the gentleman in the back.
I'm a woman.
Sorry.
My
my eyesight, you know, I haven't had a look at it for a while.
I'm just wearing a man's cap and a man's shirt. In the last 3 or 4 days, there was an article in the Tennessean saying that Tennessee had already decided by this great big committee on everybody who was to get medical help in case of a catastrophe. And they ruled out everybody that was over 85. If you're 85, you don't get any help. You just go die. I said, oh my God, I hope I don't get in a catastrophe in the next 8 years. Boom.
Thank you very much. I think we should now invite our speaker to address some of these questions.
Well, what a treat. Yeah, you all are so much more exciting than my usual class of medical students. This is fantastic. Several people have mentioned something about the correlation of the way we understand the healthcare system and the way it's currently structured and all the other elements that contribute to good health or poor health, like diet, individual behavior choices, and so on. There's no question that this is extremely important. So I haven't tried to address that at all. But I mean, if I were the health czar, one of the things we would start worrying about is health education. We would start worrying about the availability of foods in public schools that are nothing but sugar and starch and grease. I have a good friend who's really working on this very hard in the state of Mississippi in terms of trying to take all the soft drink machines out of the public school system. But there's an awful lot we would be worried about, and we would be thinking far more health consciously than we typically do. So I haven't tried to address that, but I just want to affirm that that's an extraordinarily important dimension of this set of questions. This is where I think the notion of individual responsibility actually makes some sense. We should start talking about the ways in which we can and should be responsible in terms of health behaviors, not at the point of the ability to pay for the use of the system. Okay? It is true that an awful lot of money is spent in the last year of life, the last 6 months of life, the last month of life. I'm very sympathetic with the idea that we need to understand the inevitability of human finitude. I mean, there's a sense in which if we had time, we could poll all of us and we would come up with individualized and collective senses about the notion of the right time for us to die. The healthcare system is not particularly good at hearing that and not particularly good at respecting our really deep concerns about this. I suspect a great number of you have living wills and durable powers of attorney. I hope you do. If you don't, you should. But the extent to which these get honored or even heard in large tertiary care institutions is another matter. So we have an awful long way to go in terms of making the sense of our own finitude a part of the way we place expectations on the healthcare system. This is a question I think about a great deal in relation to my father, for example, for whom I hold the proxy in terms of his healthcare decisions. But there's an awful lot of important education to do on this question. And I think actually religious institutions ought to be taking the lead on this, along with public schools and other entities. Risk sharing, yes. And here's where I think market thinking and using the typical indemnity insurance model applied to healthcare just doesn't work. If you live next to a pyrotechnics factory, you ought to pay a higher premium for your fire insurance on your house, right? Than if you live within a block of the fire station. This is the kind of thinking that, however, does not make sense in terms of healthcare, because so many of the things, in spite of all I've said about risky behaviors and health choices that we make through eating and exercise and so on, so much of the health problems that befall us have nothing to do with choices that we make, or they have to do with some really intricate combination of genetics, environmental, and behavioral factors. So this is a situation in which risk, individualized risk, doesn't make a lot of sense. Now, a lot of you probably know that Congress has just passed this business about non-discriminatory policies with regard to genetic diagnoses, genetic testing. This is a great thing. I just hope they can find a good way to enforce it. What would a national health care program do in relation to Medicare? That's a really excellent question, because some of the proposals we're going to be seeing will have to do with the expansion of Medicare down to younger age cohorts. One of the wonderful things about Medicare is that it's an extraordinarily efficient system. Many of you know that the overhead for Medicare is 3%. That means 97 cents out of every dollar goes to an actual health service, whereas the average for private insurance is something like an overhead of between 10 and as much as 25%. Now think about it. The government doesn't have to advertise, it doesn't have to risk rate, it doesn't have to show a profit, it doesn't have to have fiduciary relations to its shareholders. All of those are things which are drags on the amount of a premium or a cost that can go into the direct delivery of services. But I don't know. I think Medicare is sure to be used as some kind of model in terms of if we ever get to the point, and we will eventually, of a national health program. It may be that it will be modeled on it in some way. Whether it will affect the financing mechanisms is a very good question. It all depends on how enlightened, our leaders are on this. And the business about owing, one of the things I wanted to try to emphasize about what does society owe elders is to complicate this question a little by suggesting that in fact the kind of thing one owes elders is not distinguishable in many instances from the kind of things that we owe ourselves. This was the story of my father in relation to the question about, well, what would have happened otherwise? Could I have sent my kids to college and provided my father with 3 complete joint replacements? I don't know. It's there's something about this question that you have to work with. And that's why I wanted to focus on it. About owing something to a certain segment of the population is in some ways fine as a way to think, but in other ways it's tremendously misleading. So I'm asking for a kind of redefinition of this question in part.
We've hit 1 o'clock. I think it's time to thank our speaker for it.
Thank you very much. Thank you. Thank you.